Well, welcome and happy holidays to everybody. I'm at the tail end of my cold, so you might have a little couple of coughs and some Kleenex that you're going to get to watch as well besides the PowerPoint. And so I want to thank Silverhouse for having me here. I've done this lecture before there, and I also have done a 3-hour version for the National Association for the Mentally Ill. And this is kind of an abbreviated version of it. And my gift to you for the holidays is the, I hope you downloaded the 20-page pack. And these are great handouts. These are available for all your clients and certainly for you. And I've got my name there, and please use them as you will. So Christine, so how many people do we have on the air now?
Right now we have 26 attendees.
All right, great. All right, well, for those of you who are here early, I am going to start right away with, again, our lecture format. Sorry about that, folks. I really am. With the lecture format, and you have my introduction. I've also been working with the dually diagnosed for almost 20 years. In fact, or co-occurring disorders, people with co-occurring disorders, and I call it the CODs in this one. And the loved ones for the co-occurring disorders can be family, friends, people at work, people within the community, people in their church community, because everyone is affected, as we know, by everyone else. And especially when we're dealing with this combination of mental illness and the addiction issue. And I remember calling somebody over at AA, and I was asking, for the meetings. They do have meetings for people who are dealing with mental illness and medication and also addiction. And the fellow was an old salt, and he said to me, "Wow, who doesn't have a mental condition who's not in AA?" So I think it's a lot more pervasive than the statistics even show. So I'm also going to ask you to follow, if you have them on the handout. The lecture format that I'm showing you right now is a shorter version of all the details, and there's some nice information in that handout intro that's going to help you follow along more easily. So I'm also going to invite you that if you have questions, type them in, and at the end of this session, I will be speaking with you about them and trying to answer as many as I can. And so let's kind of start with this. Why are we treating, why is this so necessary in treating the, I'm so sorry, treating the co-occurring disorders? And I want to just look at some of these numbers. This is from the Journal of American Medical Association. And as you can see by the numbers, of the almost 60 million Americans diagnosed with a psychiatric illness, over 30 million have some form of substance abuse. And so as you sort of go through these statistics, I'll let you kind of look through them. I'll mention a few. And most of the dually diagnosed with co-occurring disorder, that kind of shifted that terminology for co-occurring disorder people. Usually use alcohol followed by marijuana. And so I go to the next slide, and you can see even more issues as far as Axis 1 and Axis 2 issues, which, by the way, in the DSM-IV, they're not there anymore. I will discuss that as well. And again, the COD have a higher risk of violence, suicide, ideation and completion, property damage, physical violence, as well as physical illness. Then if they'd only had one of the disorders present, by that I mean had they just been dealing with addiction or just been dealing with depression. And again, when I put the substance-use disorder, 47% of schizophrenics are 4 times more likely than the regular population to have F.A.C.E.D, and you can continue on down this page as well. And again, we're into the bipolars, have substance abuse disorders 5 times more than the general public. 84% of antisocial behavior, which is so dangerous because so many of the dangerous actions come out while they're under the influence of drugs and alcohol. And when I mention drugs, I include alcohol in that because it is a drug. Ethanol is something that does affect the body and the brain. and that is the drug part of it, just like nicotine is the drug part of cigarettes. So the good news is that treating families with the COD, we have research that shows that increases sobriety for the COD, increases their attendance in outpatient treatment centers, they adhere much more to the medication protocol, and they have longer periods of emotional stability. But when you think that for every one person with COD, 10 others are affected, we used to say people, as far as addictions are concerned, when one of them is affected, when there's one person with a substance abuse disorder, then in fact 7 are affected. We're up to 10, and I honestly think it's more than that. So we have a great necessity. And what's very interesting and what I'm going to talk about is I'm going to have it formed on a lot of concepts that come from family treatment models, such as the Milan model, Salvador Minuchin, and really a lot of family treatment initially came out of work with schizophrenics in the 50s. So what happened was they found that they would get the people well, send them home, and then they would relapse again into their mental illness. So they really started examining the family as a system and how that family system, when the schizophrenic returned, made them ill again. So when I'm talking about this, I'm talking about kind of a systemic process of healing the person and the family members, as well as the one with co-occurring disorders. It's like a mobile, you know, when one piece moves, everything else has to move. So with the illness, the family demonstrates its own forms of illnesses, overprotection, cutting off. Some of the siblings may be rebellious. And also, as the family gets healthier, that's part of my goal when I do my work, then it starts to move the COD to seek treatment and maintain it. So let's go on our next slide. And I also want to talk about, before I go back again, I also want to talk about the spectrum of the COD. And that can go anywhere from a low-grade depression up to schizophrenia, and from smoking too many cigarettes up to using crystal meth. So it's a pretty large range, and because of all these different components that are moving around us as therapists, it's really important to have lots of tools and maneuvers to address all these different levels of treatment. And the tools that I'm going to share with you come from my 20 years working with the duly diagnosed families. And I also just want to mention, too, you know, there used to be, excuse me for the Kleenex, there used to be this wonderful breakdown when we defined, we used to call dual diagnosis, and that was the CAMI, which is the chemical abuser that causes them to become mentally ill, and the MICA, the mentally ill that use chemicals as a way of abating some of their symptoms from their mental illness. So I think it's always important when we're doing assessments to be aware of which is present and what needs to be addressed first. The other thing I wanted to talk about is in the population is the growing numbers of the elderly. And this is a future career direction. Obviously, we're going to have the baby boomers like myself getting more and more, whatever, I can't even know where my keys are right now. But, and so we're really going to have to be aware of what's happening. And when you're working with families and have elderly parents, you want to find out if they're in a nursing home, what kind of medications they're taking. Because with the elderly, that they took medications or that they didn't take medications. They can overdose. They have higher risk of falls if they end up using certain pain medications. The action medications themselves can cause addiction. So it's very important that if you have an elderly family member to be aware and connect with the doctors who are working with them, and also if they're in a recovery home or an elderly facility. So I'm just getting all my text back here. So, okay, what are our roles as therapists? First thing we must do is assess the risk. And it was interesting because I gave a lecture at NAMI, and I brought up the 9/11 issue. But one of the things, of course, as therapists, we know it, but families are there. I got a lot of backlash from families saying, oh, well, what if they hate me, and what if, what if, what if? And it was really about their feelings of looking like a bad parent or family member or lover. for the person who they do the 911 call. However, I explain to them, whether they hate you, then they do something that is violent and to you or to themselves. And they call it a 5150. Sometimes people, if you call the 911 and you talk about getting some, someone's about getting some treatment for just alcohol, they won't often come out. If you say it's a 5150, please mention this and discuss this with the family. What that is danger to self or others. So they have to keep them in the hospital for at least 72 hours for observation, and that can be extended to 14 days. And at least during that time, they can get off of the medications, maybe go into detox and get some kind of medical treatment to help with the detox as well. So, and so as I say, we start with assessing for risk and creating best outcomes. I'm a great believer that and this comes from my family therapy training, everything is a system. The person in the workplace, with the family, with their own friends, etc. That every piece moves every other. So in our relationship, and especially in family therapy, the real basis of family therapy is we are invited in. Usually on a one-on-one scale, we can be a little bit more directive. But in family therapy, we are invited into the family, so we need to ask permission to get in there. And Ahn and Wampold, they basically said 40% determined by the client of success, but 30% from the therapeutic alliance. It's pretty powerful. And so I do, especially when we're working with families, looking at our ability to be flexible. As people have different points of view than ours, and letting them live in the room. Obviously, honesty and genuineness. And Carl Rogers has all this information, as in a lot of humanistic therapies. Certainly respect, and I want to bring in the cultural piece here, because if we're not aware, I've worked with Asian families, I've worked with African-American families, I've worked with Middle Eastern families. Being aware of the role of who has the power in the room and respecting that, even though you may not believe that's the way to work it, is we are invited into their home. So we must be cognizant of what their rules and the way the family behaves. Trust and integrity, obviously keeping our word. And the fact, too, of the honesty is admitting when we don't have all the answers, because we're really there for the family to tell us their story and find out what they want and what their goal is. I'm just getting off with the techie things here. Obviously the confidence, but it's very important to check in with the family and let them know about, and with clients, let them know about the 911, danger to self or others. You may have to call as a therapist. Please speak to your supervisors if you're at a clinic if that happens. And of course, what's demonstrated through active listening, and that really involves exploration. Lots of questioning. I'm not sure that, I'm not clear on, is what you're, the reflecting back, accurate interpretation. Well, I don't worry about having accurate interpretation, because I know people are always hearing something through a screen. So what I do is I say, I have a sense that this might be going on. Does that seem to make sense to you? Also reflection back to what we think we're hearing. And supportive listening, that can be nodding, moving forward with our bodies, making a verbal noise, I see. And so one of the things in my presentation is, and understanding this, yes, is that we need to determine in our assessment the level of support that they have in their family and community, especially for a lot of you working in inner city treatment programs. They don't have a lot. And I think part of, and I come from a social work school, and I think part of our work is to be connected to the outside systems that can give them support. And also, how aware are they of the actual problem? And what is their motivation to get well? Because people come into this at all levels. And one of the things I always want to do is bring into the room, and which I'm going to get into, ways of breaking through the resistance by breaking through the shame and blame. The last thing I have is, and I'm not going to go into it in this lecture, but client-directed outcome instrument. This comes from Scott Miller and Barry Duncan. And basically what it is a series of questions. You can go to their website. It's on the bibliography. You can go to the website and you can download a questionnaire that you ask at the end of the session. I don't do it every session, but once in a while I do it. And you can chart, they have a little graph so you can chart improvement. And it really is a great feedback tool for us as well. So, yeah, the DSM, that shouldn't be 4, that should be 5. So let's just correct that. Anyway, the DSM-V is that substance, they've changed a lot of terminology, and really they're getting back to the original concept of what the DSM-V was about, which was to move people, they've been doing this, by the way, since 1999, is to move people more towards the healthy self versus labeling them. And certainly when we're dealing with addictions, we know that denial and families of the addicts, that the denial is so thick, especially with mental illness, because there's enough shame about the substance, but if there's some family history of mental illness, it can certainly provide a kind of barrier and resistance to thinking that the parents, the family members, or loved ones have passed this on, or that they're their fault. So we want to lessen the shaming of the client. What we know in learning theory is that the more vulnerable somebody is, the less they're feeling defended, the more they're actually open to hearing lessons. So substance abuse and substance dependent is eliminated, now replaced with substance-induced disorders. There's no more axes. They're now defined as personality traits that are syntonic, which they work for the person's emotional growth, or dystonic, that interfere with treatment or their quality of life. So treatment really begins when the family members or loved ones think there's a problem. The problem may have been around a long time, but we need to at least get them connected to the fact that this is a problem. And I have some instruments in your handout to discuss how we do this. So we're going to move the clients from dystonia to syntonic, working in tune. And substance abuse, it's interesting with the DSM-V because they only address an addictive behavior of gambling and not sexual, computer, eating, and exercise. And what's really interesting, there's an interpretation of this by a fellow from F.A.C.E.D, who lectures on the DSM-V. And that is that a lot of computer people were involved with backing some of this research. So computer addiction is not even in there. They're under sexual addiction is under sexual disorder, but it's not connected as an addictive behavior. And so I think it's really important. Again, our job is to first educate and then enlighten. I think it's really important to inform family members that there are other ways that someone can act addictively with other substances, television, computers, sex, work, whatever. So this is sort of kind of the meat of my lecture. I want to sort of move towards the didactic, the teaching tasks that we have for families, and how do we motivate loved ones to attend and stay in treatment. Well, one of the big things is by the time the family, and I call this the parallel process, by the time the family has come in for help, the problems in the home have so exceeded their ability to tolerate it. And so they're coming into you with really a high level of distress. And of course, one of the first things we do is acknowledge the difficulty of this for them. But the problem is, again, is we have to somehow break down this sense of shame or this guilt feeling that, I should be the one to console. They're my children, they're my husband, they're my in-laws, whatever it is. And so I have several different ways of doing it. And at the very, very beginning, I talk here about motivational interviewing. It's with other techniques such as the pros and cons from dialectical behavioral therapy. Procahska and DiClemente call these part of their change states the pre-contemplation, when there's not even an awareness of a problem, and then the contemplation that there is a problem. The preparation to take action, and then taking action come later, and I will be speaking to that as well. So if you go to your handout, we want to assess the loved one's level of dystonic and syntonic behavior. So I've given you several charts here, and the first one is, okay, the first one is F.A.C.E.D, and that is something I came up with after they have CAGE for determining if somebody has an addiction issue, that F.A.C.E.D is for the family or the loved ones. And basically what we do is we want them to face up to the reality of what's going on. So I have this F.A.C.E.D acronym, F. Have you ever been in fear that your loved one was in danger because they mixed their psychiatric medications with a substance, were mentally unstable while ingesting substances? And they can be anything: alcohol, pot, cocaine, amphetamines, or painkillers. A, have you ever been angry at a loved one because they could not stop using these substances no matter how much you yelled, cried, or punished, or isolated? C, are you able to concentrate on your work, family, finances, or self-care? Because your focus is on the person with the co-occurring disorder. E, have you ever made an effort to get your loved one help or stop using substances only to be met by anger and or withdrawal? D, do you have a desire to try something different rather than doing what you've been doing so far? And let's face up to the fact, I think it's Albert Einstein who said that insanity is defined as doing the same thing over and over again and expecting a different result. And what my work does here as we go through these is I want to start getting them aware, getting the loved ones sensitized to their actual life situation, because many are so focused on what's going on with the person who's so sick, partly just because of the reality of the time it takes. So we're working through getting through this illusion of control. And one of my favorite writers, Thomas Holcroft, in the 1890s wrote, "People change not because they see the light, but because they feel the heat." So our job with the family, as well as the family's job with the COD, is start to turn up the heat. And we do this also through limits, consequences, contracts, and I'll get to that later. So the next question I have, this is one of my favorite, these are my favorite questions. Byron Katie is, want to read any of her work, it's very powerful. And this is my favorite therapy question, which is this belief true? I have failed because I can't stop my loved ones from getting high. Well, that's someone who doesn't understand addiction. That's someone who doesn't understand the power of mental illness. That so many factors are at play here. Even, traumatic brain injury, genetics. In poor communities, the children who are eating lead paint. And there's a big suit against Sherwin-Williams now because they knew it was bad and they kept putting out the paint, so they're having to pay to set up places to treat kids. And then after we examine if the belief is true, I asked them, can you absolutely know that this is true? And this is a good contemplation question. We want to start getting people focused on their thinking patterns, get the loved ones. And then you ask them, how do they react when they think this thought? Now, I like to connect this with somatic experience. What do they notice in their body? The trauma resiliency model also does this. Do they notice any changes, any tightening in their hands, feet, chest, throat? And really get them to be aware of what's happening. They're putting out the fight, flight, or freeze hormones, adrenaline and cortisol, which causes more inflammation in the body and takes away from the efficiency of the immune system. And then my favorite four is, who would you be without this thought? The next page, I won't go through it, is on overfunctioning worksheet. This comes from Bethko and Hester. And all that's in your bibliography. That's attached to your 20 pages. And basically, we're asking them to evaluate how they're over-functioning, because this is really the piece where Al-Anon comes in as well. How their over-functioning has affected them. Has affected their economics, their physical health, their relationships, their work health, their sanity. And at this time, it's also very helpful to ask them to think about, let's look at that page here, to think about cost it's taking on themselves. And then I also ask them the cost it takes from their loved one who is maybe not getting proper treatment because the families don't have an MD behind the name. One of the things I really used when I was working at Hazelden, I put together Hazelden, New York, I put together their family and outpatient program back in the 90s. And I created this piece, and we'll get into it later, where I'm really starting to ask the family that, it's interesting that if your child or loved one broke a leg or swallowed poison, you immediately call 911 or take it to an emergency room. But somehow with addictions and sometimes even mental illness, families think that it's their responsibility to fix it themselves or their failures. So when I start to bring up the reality that these are biological conditions, addiction as well as mental illness, and compare it to what they would do if a family member had injured themselves, they start to understand, and I educate them more on what's going on in their mind that makes them think that they can solve something that is so complex. I also have the 12 questions, which are something I came up with so the family can sort of evaluate where they are. These are great ways, these are kind of motivational interviewing ways to see where the family's at, get them to start questioning their beliefs. And so as I was saying, the removal of the blame and shame, I created this thing called the Anderson Arc of Recovery, and if you can see it, it should be in the handout. And what it is I kept thinking, how can I help these families get out of the fact that it's their responsibility so we can get them and the family member, the loved one, into treatment. And that was, I created this arc of recovery, and I sort of start on one side, the left side, is all the different causes for mental illness and addiction. DNA, hormones, neurochemistry, brain trauma, emotional trauma. And what we have discovered in developmental stage is that the age the person started to use the medications or was identified with a mental illness is often where their ability to function and solve their own problems starts. So they start to get up to this point of high anxiety or fear or whatever's going on with them. They use a substance and they immediately go back down and they create calm. Now we know it takes about 40 days, 41 days to actually cut a pathway into the memory in the brain. So think how long they've been doing this by the time the loved ones are aware that this has now become a habit. When in pain, pick up. When overwhelmed, pick up. When lonely, depressed. When seeing things, pick up. So what happens is they never get to the end of the arc, which is being able to be capable of their lives. And again, in certain mental disorders, I understand that that is always going to be limited. So what we need to do is we need to kind of build up a kind of all these bricks to support the family as well as the COD when they're experiencing this, this crisis at the peak of the arc, so that they use different tools such as the 12 steps, such as medication, and this goes also for the loved ones, such as going to NAMI. I highly recommend the National Association for the Mentally Ill. They have a 12-week program for families to attend, the National Alliance for the Mentally Ill. Very powerful. They have lectures around the country. And then, of course, for the person in need who's got the COD, they have, again, the therapy. You want to stabilize them first in therapy, the 12 steps, peer support, medication, maybe some institutionalization from time to time in cases of extreme bipolar or schizophrenia. Let's see here. Oh, okay, I'm just looking at my messages to see if anybody's done anything. Okay, so great. So again, one of the important things of discussing with the family is what are their expectations. If they understand that if these bricks that we're building up underneath this place of crisis are not maintained, that as they fall away, the family members or the person stops going to meetings, getting therapy, involved with peers who understand what they're going through, eventually they will relapse, as well as the person on the mental illness as well as the addiction. Because remember what's in the brain, it's like learning a bicycle. Once you know how to ride a bicycle, it's there forever. Well, once someone's associated with dealing with being overwhelmed with a substance work, that's there forever. So we need to keep on a pretty regular basis. Many families say, why do they have to keep going to meetings? So on a regular basis, we need to keep putting in that information about how to stay sober and therapy treatment, so that when difficulties arise, the person goes to them instead of an addictive substance. So, and the other things that are part of our job with the family is defining the signs of substance abuse, dilated pupils, and I can go into that, but there's a lot of literature out there you can go to. Another powerful piece here, the didactic task, is boundaries and contact. Jane Bluestein is a PhD in education and a brilliant lecturer. She has tons of tapes and books and CDs out there. I just showed you how old I am by saying tapes. About how to set consequences teens. But when we think about the developmental age of most people when they're using substances, it's usually about the age they picked up, which is between 9 to 11. So they may be 40 or 50, but they have the emotional responsibility and awareness of someone who's a teenager, which is pretty narcissistic, self-centered. Just going to check my time here and see how I'm doing. All right, I am at 11:34. Okay, so really, really important to, and she talks about setting consequences, not punishment, and negotiating those consequences. Well, I'd really like you to be able to go meet your friends, but I can't if you're not seeing a therapist. And you add to that contract, and you can have, I advise families to put contract on the fridge, you know, that, you know, the contract with money, a contract with behavioral expectation. And for the younger children, it's very helpful to use stars or stickers on that when they're doing the right thing. And again, for the family, remember their self-care. What are they doing? It's amazing when I'm working with families with CODs, the last they have not seen a dentist or a doctor. Their self-care is pathetic. And the explanation that by their strength, that's the mobile demonstration, by their strength, they're more able to take care of the person if they get exhausted and angry. The TRM I put there is for the trauma resiliency model. I have the Trauma Resource Institute email in the bibliography. And this is really, again, like F.A.C.E.D, really getting connected with the body, but by creating a resource. Part of mindfulness is the person in the moment. And I will use mindfulness. I will use the resource technique, which is a place that, think of a place that brings you calm, joy, and contentment. And then you go through the 5 senses of that place so that they can go there as soon as possible. Also EMDR, there's a little thing called the butterfly, which again, we're by left brain, right brain, and we're coordinating the limbic system in the brain. I have a brain diagram in there. Limbic system of the brain with the left prefrontal cortex, the last part of our brain to develop, so that the anxiety goes down. Because when people start to feel anxiety, and also anxieties about the future, you just think, oh, something bad's going to happen in the future. The person's not in the present. So, and in your handouts, I have impulse control tools such as go through your own 5 senses, the butterfly. And they do about 40 of these back and forth 3 times. It's really effective, and if parents have a kid, they can do it on their knees or on their thighs or on their hands. And also resources. And I have a lot of resources at the back of this. So please make use of them. They're there for you. Now, I want to move on to dealing with resistance. You know, one of the big things that has changed my practice a lot, oops, I don't know, like this shit. It's all eager with all these buttons here, is redefining the resistance to becoming unstuck. Irving Yalom talks about this a lot. We sometimes talk about it in humanistic treatments. Carl Rogers again, you know, they start where the client's at. And that most resistance is based on a defense mechanism that was created to protect at a very young age. And so what we do when working with families, and the families can then practice this with their COD, is that you say, I can understand why this, how hard it is for you to hear this, and I understand you're trying to protect yourself, but let's just examine how much of this defense, and I call them the defenses versus the defects, is protecting you from certain emotional stress. And then I'll go back to the motivational interviewing and that I have first, so that people can get unstuck. And again, we're trying to get them to get a new perspective on their situation, that they start to understand the way they handle this. Again, just like a broken bone or a new kidney for their loved one, they need outside help, and they need a system around them. So one of the ways, let's see, and also again back to our thing is we continue to go in and ask for permission. It's okay if we examine this as far as something that might not be making things as easy as they could be, just not talking about your feelings. And certainly teaching them things like journaling and sharing that with other people they trust is very, very powerful. I'm going to do a quick thing on DBT. There's, oh darn, again, I just want to keep pressing my mouse. Okay, the DBT, and that is that Marsha Linehan, an amazing woman. She's the one who started DBT. And basically, she's up in Washington State, and she's got her trauma. She's a therapist, and she's looking back and forth at the trees in the forest or wherever she's walking, and she starts to realize that as she thinks about her trauma, I'm sorry, I'm talking about EMDR. Sorry about that. That's Dr. Shapiro. The DBT is Marsha Linehan, and really, again, it's creating a dialectic, which is two different points of view, which is I can hate the disease, but I can love my loved one. And you come up with the synthesis. It comes from philosophy at the end, which is a new idea, is I can love them but hate their disease. I realize I have certain limitations in how I can help the family, but I also know if I go get myself taken care of and work with other parents and family members to go through this, I can actually end up helping my child. So we're getting people to solve their resistance through these techniques in DBT, and they include the wise mind that was inside all of us. There's an inner voice that really is the one. I always say, I go back to somatics. Where do you go to, that when you make a statement, it makes you feel calm and centered? That's your wise mind. The radical acceptance, I think this is one of the most powerful tools. I certainly use it with CODs as well. Because I may not like something, but for now, I can accept it. So it sort of goes back to the acceptance prayer in the 12 steps, which says I can accept things the way they are at this moment. Mindfulness, again, a lot of techniques of being in tune with the body, going through the 5 senses, being aware of the room. This is very powerful, again, when your loved ones are working with their CODs who start to get overwhelmed, is that you get them to go through the 5 senses. You get them to identify the location exercise, the farthest thing in the end of the room, and then you bring it back down to the floor and then up to their bodies and back to their fingernails. So that, again, we stop that anxiety, often unconscious, provoking thought, and get them back centered. We slow down the adrenaline, the cortisol, the fight, flight, or freeze responses that gets the heart to slow down and gets the person to breathe more deeply, and also starts them to take in more oxygen, because most anxiety and panic attacks are based on hyperventilation through fear. So once you slow that down and start taking deeper breaths, the body feels it has more oxygen and it's not feeling overwhelmed with the CO2 and wanting to pass out. The pros and cons we talked about, behavioral chain analysis, this is really interesting. It's when I sit there and pay for my loved one's new stereo because they threw it through a window, what happens is when they get angry again, they do it more and more. Now with the people with co-occurring disorders, they can get violent over any issue, and that's certainly something that needs to be discussed and what's the best way to deal with the COD, and sometimes that does mean removing them from the home. And there are several acronyms in the DBT, and you just sort of go through them for a second here. They're in your handout. Gentle, being gentle. Remember, it's context, not content. I can say, you know, I'm upset with you, or I can scream at you and say I'm upset with you. It's the delivery, not necessarily the content. Interest is listening to someone's story without giving them advice, letting your COD tell you what's going on before interrupting because of the family's own fears. Validate. Everyone needs to know that they matter. And ease, the easy manner. The more calm you are when delivering the message, the less defensive others become. And of course, we know when people are defensive, we can't get through to them. Fast is another one. Fair. People make mistakes. Apologies. Understanding how hard it is for them to change their actions. And this is also with the loved one as well as what the loved one can do with the COD. The F, stick to your values. Know your values and stand by them for the family and truthful. It takes no memory to tell the truth. So one of the things families often do to deal with the COD is sometimes your actions do have to lie, and I call it the necessary lies, especially when they may have to be taken out of the home. But in most cases, the truth I'm talking about is the loved ones giving their truth of COD about they're scared, they're nervous. Checking my time here. Okay, about 5 more minutes there. Okay, the goal of DBT is we want to develop interpersonal skills, emotional regulation skills, which I've discussed, distress tolerance skills, which I've discussed, and awareness of behaviors to increase and decrease. Now, this is an interesting multidimensional family therapy. Was created by Howard Little, and he's back there as well, and in the bibliography. And really, what it is, it's using all the different dimensions for the family therapy, and using the different dimensions within the community, family, friends, it may include the judicial, the medical, and these are all things when we're working with families of the COD. Really important because there's probably a lot of systems that are at play there, and helping to commandeer the family through those or placing them with someone who can actually take them through that. It was originally done for treating adolescents, and they found that if they had a system around the child that was watching them in the communication between the parents, the teachers, or in the workplace, the therapist, that the child actually does better. And again, going back to the developmental piece, that people are about the age they are when they start using, which is, you know, usually anywhere from 4 to 11 to 12. That's about what you're dealing with. So they really need the supervision, even if they're 40. Creating a foundation of change, we talked about the goals for loved ones. We want them, again, to connect the biological perspective of mental illnesses. We did that with the Anderson Arc of Recovery, facilitate the change systemically. And this is so important. I've talked about it before, but it's so important that before we really work too long with the family, is letting them be aware of the chronicity of addiction and mental illness. Let them know that this is probably going to be a lifetime process for their loved one and for them, as issues often get worse over a period of time with the COD if they're not seeking treatment. And the reality of relapse, which I'll go into in a couple of minutes. Create the motivation for change, which we've done. Again, we've talked about our therapeutic alliance. This is a very powerful piece, is have the family by text or email, have them contact you on individual interventions on how things are going, to and evaluate how the interventions are working, such as the contract, such as the boundaries. Sometimes The other thing is getting the family involved in certain daily activities. They, having meals together. We know it works. It keeps families more united. And the goals, of course, are pretty well what we discussed already. Goals for community and our responsibilities we've discussed. And we really want to, we're there to advocate for the system, which is the COD and the family member, so that the family member finds the balance between being the tough love or the enabler or child saver. And so relapse, it does happen, and in the first session it's so important to acknowledge the reality of this and have the family come up with backup plans such as the 911 call, explaining the 5150, and that we're coming up with consequences, as James Lucien said, instead of punishments. I'd really like you to be able to do this, so if you go to your therapist, you'll be able to play your game. If you don't go to your therapist, you can't play your game on the video. Changing the perspective for loved ones from the fact that they've experienced failure to this is a learning point, and that this is all a normal process, because, boy, once they have that relapse occur again, they feel all the work that you've done as a therapist really didn't work. And the question is, you're there to treat the loved one dealing with the relapse versus trying to get the COD to stop using, and also have a mental, emotional relapse if they're not taking their medication. And if the worst happens, which is death, sadly, being aware of NAMI, have them contact NAMI. NAMI has several powerful programs, including, as I say, let me put it here, and in resources on your sheets in the back, I have not only places to contact that you can get your clients, but also treatment centers. And then I have a mega biography here for you to do. So it's very rushed. I'm sure there's questions. I want to thank you all for listening. And there's my information there. And remember, you can call me. If you have questions, please go to my website. Go to my email, mahealth@earthing.net. And if you want to give any information about me, check out my website. So thank you very much.
Oh, Melody, thank you so much. That was just wonderful. And I was listening and I was just taking vigorous notes because everything you said was just, I really respect what you're doing with the disease of addiction. You're educating the family members, and I love how you said we're going to start saying substance dependence, not substance abuse, because less shaming, because
Absolutely.
This is what the disease feeds off of, is the shame.
Right, and they're calling them can you hear me?
I can't. Mm-hmm.
Good. They're calling them substance-induced disorders now.
Okay.
So, we're really even moving out of substance dependence. And, I think this is really getting us back to what our job is as therapists, which is really to guide people to find peace with who they are and acceptance, and give them, once they're there, then they can learn these new tools. You also just said something I forgot to mention, which is when we're working with the families, the importance of the family tree. Because you want the family to also go back, it's a 3-generational tree, and, go on any internet site for family tree, and they'll show you how to do it. The men are squares, the women are circles. I don't know how they came up with that. But basically, through the generations, is getting a sense of the DNA, of the genetics that are involved, was there further other mental illness in the family. So they can also see that they may have been the deliverers of a certain level of genes, but whatever the issue is, depression, schizophrenia, bipolar, that there's a big history with this, as well as the addiction. Because when we're talking about addictions, especially alcoholism, they have metabolic problems. The liver does not process alcohol like a normal person.
Correct.
It's in there longer. That's why you hear people, they have a wooden leg, which means you're getting more tissue damage. The ethanol kills tissue. And so the person takes more and more just to get the feeling. So there's a lot of metabolic pieces involved with this as well, including a higher rate of thyroid problems, diabetes. It's really the processing of the alcohol.
Right. And thank you for sharing that. And I really appreciate you breaking the stigma. You know, we could go to the doctor if our something's wrong with our heart or our liver or kidneys. Why is there so much shame associated with a sickness of the brain?
Because it is absolutely medical. It's absolutely medical, as is the body. It's the metabolic processing of a lot of substances. I mean, when people are on cocaine, it kicks up their dopamine, but afterwards it crashes below the normal line if you do it enough times. Well, if you've got someone who's depressed using cocaine to make them feel better, then you're going to be, if they get off the cocaine, they're going to be more depressed. So all those issues have to be introduced. And I think by really showing the family the complexities of dual diagnosis, it helps them really understand that they're limited in what they can do.
Absolutely. Absolutely. Well, Melody, I want to thank you. I'm looking. There are not any questions right now, but if you would like to submit a question or speak with Melody, mahealth@earthlink.net. You could also email them to ceu@sodhealth.com. And again, if you are receiving a CE credit, we will be sending you an email shortly. We want to thank you so much for participating in our webinar. And Melody, thank you again. I really enjoyed myself.
Happy holidays, everyone. Take care.